can be classified as very minimal to severe, and you don't have to have severe pain, severe disease to have severe pain. So what causes it? No one really knows. There are many theories on potential causes of endometriosis. The most popular theory is the one of retrograde menstruation. So that means menstrual blood flowing backwards. Okay, so going back through the opening of the tube and depositing in the pelvis wherever it lands. Other theories include some genetics may play a role, also changes that occur inside the pelvis where the cells actually change to look like endometrial cells, and that's stem cells. Risk factors for endometriosis, a really strong one is a family history. So if someone's mother, sister, especially twinning, that's a really high risk factor for having endometriosis. Also, the amount of exposure to estrogen. We said it's an estrogen-dependent disease. So the longer someone has periods, that is a risk factor as well. So a first period being at a younger age, not suppressing periods through hormones, and not going through menopause until a later stage in life. The golden question, how do you know if you have it? It's really tricky because it mostly requires laparoscopy or surgery to confirm the disease, and that is visually to see it inside the pelvis and then cut it out and send it to pathology where it confirms that in fact it is endometriosis. Can it be diagnosed in any other way? Not really, unless it has disease that can be visible with specialist scanning. So if it affects the ovary and causes an ovarian cyst, often referred to as a chocolate cyst or endometrioma, that can be seen on ultrasound. And sometimes seeing a specialist ultrasound specialist can do a special scan for deep in endometriosis and diagnose some nodules. But most patients will come to see me with an ultrasound that shows no abnormality. Treatment, we're going to talk about this a lot, so I won't talk about it in detail, but as we said, it's like the lining of the uterus, and that means it will respond to hormones. So of course, usually most people come to see me after they've tried some pain relief, non-steroid or anti-inflammatories, Nurofen, Panadol, Naprogesic, Buscopan. Some may have even been put on the pill by their GP, and that may work quite well for a lot of people. A Mirena or intrauterine device can also be helpful. And lastly, of course, surgery required to cut out the disease. There's more other medications that we can talk about. They are a bit more invasive, like Zoladex, which makes you temporarily chemically menopausal. So in summary, and we talked about, surgery. Surgery does not need to include hysterectomy. It is to cut out the disease. It's important to remember that it is not a cure for endometriosis. That is an important reminder. Even if you were to remove all the disease, 35% can recur, and it can recur even with some hormonal suppression. And people can still have ongoing pain after their entire disease is removed. So these are really big take-home messages. Surgery is not the answer all the time. Not to say it doesn't play a role, but it's really important. And Tamara will touch on other ways to help with pain, which is really important as well. And that's it. So that's the end of my slide, and we'll open it up to the floor for some questions. Tamara, did you want to say anything at all first?
About my stuff?
Yeah.
Yeah, maybe let's do that, and then we'll take all the questions after that. So as Yvonne said, I'm a women's health physio, so I deal, because I'm going to get my pelvis up in a second.
Yeah,
I deal with women with pelvic pain. So that's really pain anywhere in or around the pelvis. You don't have to have endometriosis in order to have pelvic pain, but certainly lots of my clients either do have confirmed endometriosis or I'm very highly questioning that they have endometriosis. So the pain associated with endometriosis, like Amani said, is really quite varied. It can be pain with your period, it can be pain just before you have your period and with your period. It can be pain with your period and then in between having your period, so it can come on and off. It's often pain, and I think I'll stand up.
Yeah.
Kind of down here, like at this lower edge of your pelvis. It can be on the one side, it can be on both sides. Sometimes it can go down your legs. Sometimes it's just with intercourse. Other times it's when you empty your bladder or when you empty your bowel, all of which can be quite confusing and obviously is very varied, like I said. So what we deal with as women's health physios is the muscular component to the pain. So it makes sense, of course, that if you have pain in any area of the body, the muscles in that area tighten. It's not unlike if you get lower back pain, all of a sudden your lower back muscles go into spasm. It's the same with the pelvis. So if you get pain in the pelvis because of endometriosis, then the muscles on the outside and the inside of the pelvis tighten up. And the thing with tight muscles is that then they create pain. And it's actually the same pain. It's like an amplification of the pain that you're already feeling, which is not cool, really. So what we can do as physios is actually go in and loosen those muscles. And if we loosen those muscles, then we can manage or help reduce the degree of the pain that you're experiencing. So just so everyone gets an idea about the muscles that we commonly loosen, here is a pelvis. So I'll just orientate you to the pelvis to start off with. This is the front of the pelvis, so the pubic bone at the front. And this is the back of the pelvis, so the tailbone at the back. And the pelvic floor actually sits at the base of the pelvis. So it sits at the floor like this. It really creates the floor of the pelvis. That's why it's called the pelvic floor, of course. So it's got two layers, just to simplify it. There's an outside squeeze layer. It's really circular. That's what you see when you have a look at a vulva. It's the vagina entrance. So it's the squeeze layer. The deeper layer lifts up. So it's more that bowl-shaped one. So together they squeeze and they lift, and then they also drop and open. So it's important that they both go up and down. In a person that has no pain at all, the pelvic floor, generally speaking, sits dropped and opened and relaxed. But as soon as you start to input pain into that person, the pelvic floor, like any other muscle, starts to tighten. And generally speaking, it will start to live in a little bit of a squeezed and lifted zone. And as soon as it's there for any length of time, if you have ongoing pain, then the muscle will get tight. That tightness then causes the pain, that same pain. So what do we do about it? We go in and loosen it. And this is where our women's health appointment gets a little weird for some people.
I always tell my patients what to expect.
Yeah, good. We often ask that, you know, what we're going to do here today? Because it becomes an internal exam. So it becomes a bit like a gynae appointment because we get to the pelvic floor via the vagina. So we'll go in, we'll feel whether we think the pelvic muscles are tight. Obviously we felt many, so we have a pretty strong idea as to whether we think they're tight or not as soon as we feel it. But also we check to see whether it can move, because the pelvic floor that's tight usually lives up here, and because it's so tight and tired, it really can't squeeze and lift all that well, and it certainly can't drop and open very well. So if we feel like it can't move, if we feel like it's tight, then we start to loosen it. We poke on it and loosen it as we would any other muscle in the body. So just if you had a tight neck, then we'd loosen your neck muscles, then you could move your neck again. It's the same with the pelvic floor. Often when we poke on it as well, it kind of recreates the pain, which is cool, but not cool. So obviously if we can get rid of it, then it kind of makes sense for the person. So often, or sometimes, it is a bit varied, to be honest, it's the whole floor, everything is tight. But equally, sometimes it's just little sections of the floor that's tight. Sometimes it's just a little bit up and on the right and a little bit down and on the left. It's all a little bit different. But either way, we loosen whatever we think is tight and then voila, you're fixed. No, of course not. We don't live in a perfect world.
Not so easy.
No. You know, and obviously if your endometriosis isn't under control, if you've got your painful periods coming back every month, then the tightness can come back. The tightness comes, then your pain can come. But even, I have to say, even if, you know, and Amani touched on this before, even if Amani's done an amazing job at getting the endometriosis under control, even if you're not getting your periods, let's say, so there's no input from it at all, we can find that actually the pelvic floor comes back up tight again and can create a degree of pain in that way. So I think, you know, that's where us as women's health physios these days have started to actually look beyond the pelvic floor when it comes to treating women with pelvic pain associated with endometriosis. So, you know, we can see someone 1 week, we loosen their pelvic floor, we think it's moving better, it feels a little bit better. They come back the next week, no period, no pain from that. We don't think everything's, you know, been settled down, and it's tight again. And the tight parts are back and they're causing pain again. So what we do these days, we kind of think a little bit more broadly. So, I mean, just to kind of make it make sense, you can imagine a person in pain, it's not just their pelvic floor that goes up, their whole posture changes. They're not generally this like open, you know, knees wide, upright person. They're usually down and in on themselves. It changes your posture.
Pain posture.
Pain posture, yeah, exactly. So it changes your posture completely. And a posture, particularly with the pelvis, I'll just pull this down. So they're almost like a little pretzels, I think, when they come into the room. So the shoulders are down, their legs are crossed, and everything's kind of rotated, hips are in. And they've often got their belly on, like they're really gripping with their belly, they're gripping with their bum, like everything's tight, their jaws are on, everything's tight because they've been in pain for so long. And you can imagine that a pelvic floor, you know, that's sitting on the inside of the pelvis probably doesn't love it if it's rotated, the hips are squished in, the belly's on, the bum's on, everything kind of gets a little bit tight. Pelvises don't like to live here all rotated and squished. They like to live here in the center with the hips perfect in their sockets and the pelvic floor dropped and opened. And if it's living there, then the pelvic floor, we think, is much less likely to tighten up. So these days we don't just loosen the floor. We also have a look at where women's pelvises are in space, so where they are when you're standing, where they are when you're sitting, and we loosen whatever we need to in order to kind of get it out of that twist and that compressed state. So often it's stuff around the pelvis, like your hips or your glutes, but we're finding more and more, the more women we see, that sometimes it's their feet. And sometimes it's their ribs. And
is this why some of my patients also say they're doing breathing exercises?
Exactly. That's why they do breathing, because the belly connects into the diaphragm and the diaphragm connects into the belly and then into the pelvic floor. And we see pretty much everyone with endo have altered breathing patterns because, you know, if the floor's up, you can't.
Shallow breathing.
Shallow breathing, exactly. So we change all of that. And we think if we do that, you know, we see it clinically, the pelvic floor lets go. So I think at the end of the day, take home message from me is just know that women's health physios, they can help people with endometriosis by dealing with the muscle component of the pain. And we do it not just by loosening the floor, but also by kind of looking at the whole body these days as well.
Well, anyone with back pain, I can't imagine, would have any treatment without seeing a physiotherapist for their back pain.
Yeah,
so
exactly. So
no
it's exactly
different.
The same. Yeah, it's just confusing as to why.
Yes.
Yeah.
Thanks, Tamara. That was a great explanation.
Thank you, Tamara. I've got a couple of questions here that have come through from our attendees. We'll start with the pelvic floor, since that's what we're talking about at the moment. So the first question is, should I do pelvic floor exercise? If so, how many?
Not necessarily is the answer. So, I mean, obviously we want your pelvic floor to move well, but if it's up here and we get you to move it, I just said it doesn't really drop and open very well. So often we can create more tightness. So first step would be seeing someone to make sure that it can let go and loosen and move well. And the next step might be moving it a little bit, but certainly not a lot, because too much is too tight, essentially, and the tightness is the problem at this stage.
So the next question that goes along with that is, can I loosen my pelvic floor myself?
Love that one, everyone.
Thanks.
Yes, you can. I think it's always good, though, to go see someone first, just because you know, the deeper layers are harder to get to than the outside squeeze layer. So certainly you can get to that bit yourself. It's almost like perineal massage, like you do when you're pregnant near the end. You'll know about that soon, Yvonne. So you definitely can get to that squeeze layer. You can also get to the deeper layers. We have things called TheraWands. They're funky little devices that you can insert up into the vagina and loosen whatever parts we've kind of told you are tight. So they do work really well for some patients, especially if you live rurally or if it just keeps coming back and you just can't quite change your postures completely. I mean, that's the reality sometimes, isn't it? It's hard to change everything. So they do give you some tools. There's also dilators. We don't use dilators a lot in our clinic, but they certainly are used pretty widely, and they can be a good tool to try and help open up particularly that entrance, that squeeze layer as well. And they're also good for those that are rural, and also good if you've got dyspareunia. So that's the pain with sex.
Lovely. Okay, so actually you answered one of the next questions, which was somebody has been prescribed dilators and they for their pelvic floor tightness, and they want to know, do they work?
Yeah, well, they can work. It's just if the tightness is up through those lift layers, that bowly bit, they don't quite get to those bits. That's where the TheraWand will work better. But they're particularly, you know, people generally use them for dyspareunia. Okay.
Lovely. Okay, Amani, I've got some questions for you now. So number one is, how do I know if I need surgery for endometriosis?
Okay, that's a very good question. The first part of that would be to see a gynaecologist that specialises in endometriosis and have a chat. So talk to them about your symptoms, about your pain. They'll also talk to you about your risk factors and really gauge whether or not you are high risk of having endometriosis, or they think that that is the main cause of your symptoms. Examination is also a part of that assessment, because sometimes we can feel nodules in the vagina if they are quite deep. And surgery is really indicated when someone has tried medical treatment, medication, hormones, the pill, and it's just not working. So it's really important when you do put a treatment plan to follow up and make sure that it's working, because for a proportion of women, medication just won't cut it. And it's really important to then move on to step 2 or backup plan, and that would be surgery.
That's because they still have pain, or they
Correct.
still have
Yes. Correct. If their pain is not alleviated by the pill or an IUD and they're still having pain, it's important not to live with pain and not to delay review and surgery. And as Tamara's mentioned, the longer you have pain, the longer you're adopting those pain postures, it can have other effects on your body, not to mention, that's physically, of course, not to mention the mental health impact that can have. And we know that women with endometriosis, women with pain in general, can really suffer from mental health disease, because pain is awful. It's suffering, and that can lower your mood, and that's an important component.
Yeah. So the next question when we're talking about surgery is, what are the risks involved with surgery for endometriosis?
Oh, that's a very good question. So firstly, the trick is, and a tip is to make sure the gynecologist or the surgeon doing your surgery is someone that is specialised and does a lot of endometriosis surgery. We, as we call it in the field, in gynecology, it can be some of the most difficult surgery. I have, as I mentioned, a team that I work with. So for example, my colorectal surgeon, not all colorectal surgeons do endometriosis surgery. So it is really specialised, and you need to find the specialists that do that, because outcomes are directly related to, I guess, experience and risks also. So it's important to choose someone that does it a lot.
Is that because it's hard to find?
It's because it changes anatomy.
Yeah,
so
okay.
We learn anatomy, we know what to expect, and then endometriosis comes. You don't know what to expect until you go in.
Yeah.
So it's more difficult to plan, and it'll throw you off, because you'll have nodules that make the bowel stick to the back of the uterus, or the ureter stick to the ovary, and then when you're trying to unstick them, it can cause injury.
Yeah.
So it's really unique surgery, and it requires a unique set of skills, because cutting out that disease, normalizing the anatomy, is what alleviates people's pain, because it reduces that inflammatory load. It unsticks the frozen pelvis. But that can be quite difficult depending on how severe it is.
Yeah, so you've got to wing it.
Exactly. And it's not without risk. Sometimes there can be, and now it's all done through keyhole. So please make sure, if someone recommends open surgery, maybe seek a second opinion first. I say that for everybody. That is recommended. That is the current guidelines for all women. Make sure you do seek a second opinion and see if keyhole or any minimally invasive approach is appropriate for you, because that means less pain, less risk, earlier recovery, less adhesions in the future, all these benefits that I think all women should have the benefit of having as an option. It's not always possible, and sometimes a big open cut is necessary, but it's important to make sure that that is the only option.
Thanks, Amani. So I think that ties into this question here from Sarah, who's asking what your opinion is on having a hysterectomy at an early age, and that's being in your late 30s, when you do have endo and extremely heavy periods and you haven't responded well to hormone treatments.
Thank you, Sarah, for that question. That brings me to talking about often the coexisting condition that it surprises me that till today a lot of my patients have never heard of, which is adenomyosis. So that's like endometriosis cousin. It's pretty much the same condition, but the location is different. So we said endometriosis is when the lining goes outside the pelvis. Adenomyosis is when it goes into the muscle of the uterus. And as a response, the muscle thickens and gets bigger. And it's got these little islands, bubbles of inflammation, and they bleed with the period. You can have bleeding in it. And really the pain is described often as contraction type pain. It feels heavy. It can radiate to the back, down the legs. It can cause pain with sex. And it can cause heavy bleeding, constant bleeding, bleeding in between periods. Sometimes a Mirena might help, but often it doesn't. And heavy bleeding is a problem, and it can really debilitate people, and that causes iron deficiency, which has its own series of complications. It makes you feel crook, it drains you from all your energy, makes your heart work really hard to deliver oxygen to all your systems that are struggling. So a hysterectomy is the answer for someone in that condition that has completed their family. I don't think it's a matter of age. I've heard that before. Some of my patients have come to me saying, I'm 33 and no one will offer me a hysterectomy. I've tried everything and I'm bleeding constantly. But they've had 3 children and they've completed their family, don't want any more, or they have chosen never to have a child, and that is completely their choice. So my philosophy is it's your body, and as long as you are adequately counselled and able to make that decision, it is your decision. And as long as it is, like I said, it's not the right choice for just pain, but pain and bleeding that we think are due to adenomyosis can be fixed with hysterectomy.
Okay, lovely. I'll just take a moment there to say I'm just going to open a poll for our attendees, which I'll do while you guys continue to answer the questions. But while we're talking about fertility and falling pregnant, there are a couple of questions around obviously infertility and falling pregnant. So the first question is, what is the best treatment for infertility caused by endometriosis?
That's a very good treatment too. And you'll find that the medical world is divided into 2. Some that think surgery is the option because we know that cutting out all the disease can actually double someone's chances of falling pregnant. But at the same token, IVF can overcome the difficulties or the problems that endometriosis has on fertility and result in success. So my philosophy is that both of those, and actually one of the papers I published was on answering this question. It only took me a few months to do the research, and it's tricky. And I have a little table there because it really depends on each scenario and each person and their particular concerns. So I'll give you an example. If someone, because it depends on the other factors too. So for example, if a woman is 39 or 40, so we have advanced maternal age as well, and that can reduce someone's fertility. So there's another factor potentially adding to that trouble. And they have endometriosis. I think we do a blood test to see what their ovarian reserve is like, and if their disease doesn't distort their anatomy to a point where we can't get to their ovaries, because that can happen, then usually IVF is the way to go. Again, this is really simplistic, and you would really want to make sure you have a chat to a specialist in fertility that also does endometriosis. But if someone, say a woman who is 31 that has pain and also has been trying to fall pregnant for 12 months and her ovaries have a really good reserve, then I think that is someone who is a good candidate for surgery, because they can have the time. It's not going to impact them negatively than trying for another 6 months.
Lovely. So we have 2 questions from this attendee. So the first question is, I have had a hysterectomy. Can endometriosis return? My daughter also has endometriosis. Does early treatment help in management?
Very good questions. So yes, after a hysterectomy, endometriosis can return because you have ovaries. So as long as the ovaries are not removed, there is hormone production. And as I said, we don't really know what causes endometriosis. So hysterectomy removes and takes away that theory that it's all from backward flow of bleeding, because there is no more bleeding. That there are other theories that say that endometriosis can actually transform from cells that are already there in your pelvis. And we know from research that that can happen so long as someone has functioning ovaries to produce those hormones. I by no means think that we should remove everybody's ovaries and put them into early menopause, because that has risk in itself. But we know that women that have their ovaries removed at the time of hysterectomy have less chance of needing more surgery, which is, I think, about 8% if you've just had a hysterectomy with ovaries that are left in place. But it's also important to remember, as we've discussed, just because you have pain after surgery does not mean that your endometriosis has come back, because there can be other causes of pain, and pelvic floor, as Tamara has outlined, is a major concern and can be a cause of that pain. The second part of that question was, should I get my daughter checked, I think, if for the same thing. I would say definitely if she has symptoms. So if she has pain, heavy bleeding, then she should be reviewed. And that comes to the question of, should we preempt treatment without symptoms? And the answer is no. Endometriosis without symptoms does not require surgery and does not require hormones or medication. A lot of people can have endometriosis and never know about it and fall pregnant, and it causes them no issues at all. Good to be aware of it and to keep an eye on things, and that leads to early intervention, but it doesn't mean you need to worry. Yeah.
Lovely, thank you. We'll just throw back to Tamara now. So Tamara, what are natural therapies for the pain caused from endometriosis?
What are natural therapies? What do you mean by that? Ooh, what do you reckon, Amani? Natural therapies,
yeah, so
like food.
Yes.
Yeah.
Well, I mean, physiotherapy is a natural therapy. It is part of the complementary therapies.
Correct. Yeah.
It's an evidence-based complementary.
True. That it is.
It's something whenever you are looking at complementary or natural ways, natural therapies look at what has evidence. So for pain, diet and foods is a big one. Yeah. So there's lots of research now into the role of FODMAP diets that is often used for things like IBS or irritable bowel syndrome. Endometriosis is a really inflammatory disease, and food can be quite inflammatory, and it can trigger that. It can give you pain, it can result in bloating, and all the inflammatory, you can get nausea, feeling really tired. So seeing a dietitian to look at your food and perhaps do an elimination diet or a FODMAP diet. Some people do find benefit with magnesium supplementation if they get really bad cramping. Primrose oil, evening primrose oil has been shown to have some effect. Acupuncture that is done regularly can also be good. And don't forget mindfulness and cognitive behavioural therapy, so psychology. Lots of apps now are available, you know, on your fingertip, just on your phone, to practice mindfulness, and that's part of what you do with the breathing.
100%. And exercise.
Exercise, yeah, very good.
Natural
Endorphins.
Yes, make
positive.
you happy.
Yeah, absolutely. Yeah.
All right, lovely. And just another one for you, Amani. So Jolene here is wondering how, if you're seeing younger girls presenting in your rooms these days, and if so, what is your first line of treatment?
I do, yes. I see young women that come from all parts of Sydney, actually. And I think mainly because they've heard this rhetoric that, well, you're quite young, you can't have endometriosis, or often they see doctors with pain and they feel like they have been dismissed. It is a myth that young people can't get endometriosis. There's studies that have identified endometriosis in young people as young as 8. Yeah, so it's more common once someone starts having a period, but really important not to let young people, not to deny them treatment. I think depending on their risk profile and what they would like, again, it's a discussion and everybody's different, but first line could be the pill, and not just the pill, but skipping your periods. No period, no bleeding, and I haven't met a teenager that doesn't like the idea of a period. No one needs a period. It's not a healthy thing to have a period if you're skipping them the right way with hormones in a safe manner. So, and if that helps with your pain, then that's fantastic.
Okay, thank you. So we'll just take a moment from the questions to have a look at our results from our polls. So I'll share the results with everybody now. There we go. So, well, 94% of our attendees have endometriosis. So, good start. So, how long did it take to reach your diagnosis? So, as we can see, I'm a
little bit excited about that because often that shows that we're actually improving the status quo, because it's been quoted in Australia that it often takes on average 8 years to get a diagnosis. So I'm pleased to see that 24% have had it diagnosed in less than a year, and then 40% 1 to 5. I mean, we could do a lot better, and that 5 to 10 is just too long. So that's but yeah, I'm glad that it's improving.
That's good to hear. Okay, so then we have how old were you when you were first diagnosed?
Yeah, again, yeah. So the big proportion, over 50%, 20 to 30-year-olds.
Yeah.
And that's what we see in clinical practice. Yeah.
Lovely. And then do you feel like your disease is well controlled?
This is really bad, you guys.
Yeah, that's not good.
Oh my gosh. 65% saying no. What's going on? Talk to us. Tell us why.
Yeah, what is it?
Yeah, what is it? Why do you feel like your disease is not well controlled? Yeah, just you can write a comment, even as not a question, but we really want to hear from you. I mean, why has it not worked? Tell us.
What have you had done?
Yeah,
that has then not worked.
Yeah.
Well, I will let you know if anything comes through. So
move on.
we can go back to some of our questions. We've had a few more while we were going through the polls. So I had my tubes clamped at my C-section, so have no need for contraception. I haven't been able to stomach the contraceptive pill in the past. Would a Mirena or other hormonal be useful for managing pain?
Yes. And, you know, just as with teenagers, for example, that have never been sexually active and don't require contraception, we would be using that for pain management, and it would be just as effective as if you didn't have your tubes tied, which works for a lot of people, but there will be a percentage of women that will need more treatment.
Right. So talking about surgery, we have another question around how often is surgery actually required? So one of our attendees was diagnosed in their early 30s and was told after their first surgery that it would be unlikely that her endo would return. However, after about 3 years later, the pain returned, and she went back to her surgeon and was surprised to find that the endometriosis had returned. She'd like to know, am I likely to require further surgery? And now that she's in her early 40s, she never went down the IVF path, so she's never had children.
Okay, that's a really good question. I think there's a big revolution in endometriosis world, and what we're really trying to change old practice, and gone are the days when we want a woman to have, you know, 20 laparoscopies, because that is not doing any good. We know that endometriosis is chronic. We know that it comes back, and surgery is not a cure. Sometimes hormonal suppression at the time of surgery can reduce that, but it can happen up to about 50%, and even with hormones, 35%. Is it more likely to happen after the second time it has been removed? No one really knows. Pain can come back and you may not have endometriosis. Options are to explore other, I would say, if you have pain and you've already had 2 surgeries that have completely excised the disease. Of course, one would be to make sure it's not adenomyosis, but you still have your uterus, you could be getting pain. 70% of women with endometriosis will have adenomyosis. It is often missed.
70%?
Really high.
Yeah.
Really high. Because they're pretty much the same thing, and it's just the location. So it's important to make sure that that's not the contributing factor, because that will have its own options for treatment, and exploring really getting down to
Is ablation an option?
That's a good question.
Ooh, good.
Ablation helps the bleeding.
Mm-hmm.
However, uniquely with adenomyosis, it can create worse pain.
Great.
Yeah. Yes.
Okay.
Because it's actually, ablation is basically burning off the lining of the uterus. The problem with adenomyosis is the muscle. And for some reason, it seems, we don't really understand why, but perhaps that burning off that layer really triggers an inflammatory response from the muscle.
Okay.
It just doesn't like it.
Okay.
And some people never have pain and experience pain for the first time after ablation.
So do you do that much?
No.
Yeah.
I can't remember the last time I did an ablation. Also, because now we do laparoscopic hysterectomy. So if people are not responding to Mirenas or hormones and other medication, their first they want a definitive response. You can still bleed after an ablation. And often, you know, I've never had someone regret having a hysterectomy. If they've been suffering with pain and bleeding after keyhole surgery, they're in hospital for a day or 2, and then up and back to normal activities.
Yeah, nice. Yeah.
Okay, thank you. So we have a comment here from one of our attendees who said that they've had 3 surgeries and they don't have any pain, but they now have horrible bleeding every month.
Yeah. So that's again looking at the adenomyosis to see, and also excluding other things. So bleeding can be, you can have bleeding from a cervical abnormality, or if it's coming from the uterus. So it's a shame. You fix all these things, and you know the pain improves, and then you have another symptom.
So in regards to bleeding, so one of our attendees, Jennifer, has asked, is getting big clots in your period, would that be a sign of endometriosis?
Not necessarily, because clots are not uncommon. They can happen. I would say if the bleeding is very heavy and abnormally heavy, and that's difficult to quantify because it's very subjective. So everybody's experience, and often people don't realize that their symptoms are abnormal until they've had a chat to their friend or someone, and they're like, oh, what do you mean? You don't get that? That's just me. That's it. So maybe it could be a sign of heavy bleeding, which in itself could be a sign of something else. But in its own, maybe not.
Okay. So, Tan, this one's back to you. So, if an adolescent is realizing she may have endometriosis or at least pelvic pain, at what point should she seek the help of a women's health physio?
Yeah, so a few colleagues of mine see adolescents and even, tween type age groups, and we absolutely can see them at that stage. If they haven't had intercourse yet, though, generally speaking, we won't do an internal exam unless, of course, there's unique situations in which case we could and would, but generally speaking, we wouldn't. Again, we'd just be seeing where their pelvis is in space, whether we think all the muscles on the outside is tight. And we can also use what we have in our clinic, which is a real-time ultrasound. So this ultrasound, we have a look at the bladder, and by visualizing the bladder and then getting them, using certain cues to see whether they can move their pelvic floor, we can see whether, well, essentially when you squeeze and lift your pelvic floor, the bladder on the screen is meant to lift, and as you drop and open, it drops back down. So in people that have, a loose, open, moving pelvic floor, the bladder will go up and down on the screen, and this is just through the lower stomach, so it's not invasive in any way, shape or form, but often we'll find that, it's not moving at all. And that combined with, tight hips, lacking range, not great breathing, tight stomach, and all these other things that we tend to see in people with pelvic pain, like tight jaws and necks and feet, plantar fasciitis. So we can treat all of that and have a good outcome when it comes to those people. So
and I've got a question, Tamara, please.
Yes.
How long does treatment on average take? So how many visits?
That's a good question. It is hard to answer that question.
Yeah.
Often, it's changing, I suppose, your entire, the way that you exist. So the way that you stand, the way that you sit, the way that you move. And it depends on, of course, how well controlled your endo is as well. So how much pain is coming in from that as well. So often we do see people for years, but not necessarily, not every week. In the beginning, we see them more often, so once a week or so, just so that we can figure out their bodies, loosen their pelvic floor, and really kind of instill in them an understanding of what's going on, so that then they control their muscles a little bit better. And then we space it out as far as humanly possible, just to keep everything under control.
Great. And I think what you're highlighting, and I think also really key with endometriosis, and you've mentioned it, just being aware of your body and knowledge. So, knowledge is power. And I think that's a key point, especially with a chronic disease like endometriosis. So whether it's for pelvic pain, and knowing how you behave from how you breathe, how you sit, how you stand, and also knowing about your disease, you need to take control back. And when you do, you'll be able to actually, whether it's, if you eliminate certain foods in your diet and you recognize, okay, this is a trigger, this will give me a flare up, it doesn't mean that you should never have that. It just means you have control. So you might know that, oh, okay, if I have this, I might expect a little bit of bloating or whatever. It's fine because I really like ice cream. It's fine. It's not, but it's you taking control. It's you knowing what your triggers are and how you might be able to help yourself. The Pain Society Australia, if you haven't been on their website, they have some great resources as well, and they'll go through yoga poses and certain things when you are experiencing pain, how to perhaps help yourself. And that's really important. So
100%. We love to give people like a little individualized program that they wake up and they do in the morning, and it just makes them feel better for the day and more in control. Exactly.
Thank you. So we've got a fertility question here. So what could be the cause of low ovarian reserve in someone young, that's at 31 years old? Can endometriosis cause this?
It's a very good question. Endometriosis can, if there are endometriomas. so those chocolate cysts. So there's different type of endometriosis, and people classify it as 3 different diseases. And the one on the ovary, or endometriosis, is its own entire entity. And endometriosis is a really enigmatic disease. So there's a lot that we don't know about it. It behaves very differently, uniquely in everybody. But if you have a chocolate cyst, it's a chocolate cyst because that's all old blood. As we said, whenever you're having a period, the same thing's happening inside your body. So in the ovary, every month, it might be growing and you're accumulating old blood. Old blood is really rich with free oxygen radicals, and that can be detrimental to eggs. So we know if you were to have an anti-Müllerian hormone, which blood test, or AMH, that tests your ovarian reserve, then that will be lower if you have an endometrioma. Unfortunately, it will go even lower if you then have surgery to have that endometrioma removed.
Oh.
Yes, and that's where it gets really tricky. And in fact, in women that have endometriomas on both ovaries, having surgery for both ovaries, there's a 1 to 5% chance of putting them into menopause. So you can only imagine how there's lots of little nuances of managing fertility with endometriosis, and it's important that your specialist has a knowledge of both endometriosis and infertility, because it's a very tricky interaction. So yes, it can, but there's also other factors that can result in low ovarian reserve. Mostly genetic is one of them. So we're all born with a set of eggs, and unfortunately we're doomed from the moment we are born to lose follicles. So from birth. And in fact, the highest number of eggs a female will have is when she's a fetus in her mother's womb.
Really?
Yeah. And then after birth, it just goes down, 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 down. And after 35, the curve becomes quite steeper. Yeah. So other things that can reduce it, lifestyle factors like smoking, big impact. We know that women that smoke have lower ovarian reserves and in fact go through menopause earlier. So anything that can be toxic to eggs. So that's a big factor. And yes, endometriosis can.
Okay. So is pregnancy more dangerous if you have endometriosis?
Also a very good question. And it brings me to debunking a very age-old myth that, oh, just get pregnant and it's going to fix you. No, it won't. It will not fix you. And in fact, there are potential complications, yes, that can occur in pregnancy that are unique to endometriosis. Having said that, the reason people historically have said that is because the symptoms tend to get better with pregnancy.
Yeah, you feel great when you're pregnant.
You do. Yes. But hey, guess what? It's because you're loaded with progesterone, and that's the antidote for estrogen, which activates endometriosis. So it just settles everything down. It's like being on the pill or a high-dose progesterone therapy. So it tends to go quiet. But the moment you have periods again, if you breastfeed, once they come back when you stop breastfeeding, it will come back.
So you just get pregnant again.
Non-stop pregnancy. No, don't do that.
I wouldn't recommend that.
No.
So is there a link between endometriosis and weight gain?
Well, that's interesting. Not that I know of.
I don't think so.
Yeah.
Yes.
However, if there's a link between endometriosis, pain, and depression and anxiety, depression can make you gain weight. So if you are in pain, you're less likely to be active. You're more likely to stay indoors. You're more likely to avoid being social and interactive. You're probably really fatigued as well. Fatigue is a sign of endometriosis. So in that way, you can change your whole lifestyle, and that's not going to be one. If someone's in pain, it's not going to be one of a very active, healthy lifestyle, and that can make you gain weight indirectly.
Tight and
yeah, that's true.
Lean.
In fact, thin. Yes.
Yeah.
So a low weight or a low BMI is a risk factor for endometriosis. Rather than having a high BMI.
Okay. So we've got Alfina here who has written when we were talking about delayed sorry, I've lost my words now, diagnosis of endometriosis. So she's written here, while I feel my endo isn't well managed, before I had my last pregnancy, so the second child is 8 months old, I was managed with an anti-inflammatory diet, heat packs, and pain relief during my period. My recent second period, after stopping breastfeeding, had pain for 3 days, which continued down the backs of my legs. As a busy mum, part-time student, and a full-time career woman, I tend to put my own health second.
Yes, you're
Wrong, I know, and we all do it. And even though I have private health, private specialists, and surgery are expensive. My first laparoscopy took lots of returning to my GP. At the time, he did 7 pregnancy tests over 5 weeks of chronic pelvic pain, refusing to look at any other options before I took myself to emergency, who gave me a referral to my obstetrician gynaecologist. I suppose this back and forth has made me reluctant to seek further treatment as well.
That's really sad to
Yeah,
hear. And
absolutely.
sorry you're going through that, but please do not despair, and please come back and see someone. You're clearly young and busy, and you've just got no time to be in pain or suffering, and there are very many options, and we can help. So I'd like to restore your faith in us. Please let us do a better job, and there are options. And one thing to be aware of is, if you've had endometriosis in the past, you may have not had adenomyosis at the time, but you've got the risk factor for it. And in fact, sometimes it's triggered for the first time after having children, because every time, a big risk factor for adenomyosis is pregnancy itself or a miscarriage. It can be more so a cesarean. But remember, it's the lining invading into the muscle. Every time a placenta attaches, that's exactly what it's doing. It's forming these channels of blood with your own circulation to feed a pregnancy. And then it comes out and those channels are open. And that's a really good time for the lining, the cells, to actually just follow the tunnel into your muscle and deposit there. So the more babies, the more pregnancies, that's a big risk factor. So you may have developed adenomyosis by the sounds of things. And there are options for treatment.
So what can you do? What can you do?
Treatment?
Yeah.
Mirena works well because it's deposited right there. And that's a really kickoff of Mirena. It wasn't designed for this. It was designed as a contraceptive. But because it sits in the uterus and it delivers progesterone, again, we said pregnancy equals progesterone. That's why things quieten down. It delivers progesterone to that area, which kind of counteracts the effects of estrogen, so it dims down that inflammation and it stops the bleeding. So it stops, most people don't have a period on Mirena or have really reduced flow if they do have a period. So it stops that chance of those cells further going through those channels and making things a lot worse.
So can you get that after you've had your baby, when you're still breastfeeding, before you get your period back? Yeah,
exactly. So
it's not going to affect your milk.
Definitely not.
No.
At 6 weeks, all my patients that I know have endometriosis and I've delivered them. First thing we do is pop a Mirena. Completely safe to do. And yeah, the trick is getting to it before it starts.
Yeah.
Lovely. So another question about symptom. Oh God, I'm having a shocker, aren't I? I'm just going to ask the question. Okay, I suffer from migraines and have been told that migraines and endometriosis go hand in hand. Is this true?
I definitely see that a great proportion of women with pelvic pain, and especially if they've got endometriosis, come in with a history of headaches.
That makes sense. Is it the tension?
I think so. Yeah.
They're both the same thing, aren't they? Spasm.
Exactly. So it's often coming from the muscles at the base of the neck and their jaw clenches. Have you noticed that as well? Yeah. So they've often been to their
interesting.
dentist.
I've never thought of that.
Yeah. So they clench their jaw, their neck is tight. Yeah. So they often do have headaches, and it is one of the questions we ask straight away, because pretty much everyone has it, which is a
very good
link.
Yeah.
All right.
All the time. Get your neck treated.
Yeah, it'll help. Yeah.
So can endometriosis cause organ perforation, example of the bladder, if not excised?
Oh, that's interesting. No, not usually perforation. It can, however, cause obstruction of the bowel. So not all the time, it's not common, but if you get really big, bad nodules that are really thick and going through the bowel, it can really affect function, and causes, functional problems like constipation, not to mention pain when you're doing the poo, blood when you're passing the stool, or mucus. But it can have an effect on function as well.
Okay. Wow, we've got a few questions, but I think some have been quite similar to the questions that we've already asked and answered. I think we're doing okay. I think we've answered most of the general questions that have come through. I think there are some questions, both Amani and Tamara, that I might get you to have a look at and answer personally to some of our attendees. But I think on a whole we have answered all of the questions asked, and I don't see any more on our chat. So I think that's it from this end.
Excellent. Well, I hope you've all found this helpful and useful, and I hope it makes a difference for anyone who feels like they're struggling or just needs a little bit of help.
Lovely. Thank you both for your time tonight. It's been very informative, and as I said, there are some questions that we will answer offline. But thank you to everybody for attending tonight, and I hope you enjoy the rest of your evening.
Thanks, everyone.
Bye. Bye.